All right, we're going through the knee pain with running series, and if you've already listened to the other ones, I hope you're gonna like this one too. We've already gone through IT band syndrome, runner's knee, medial meniscus tears, patellar tendonitis, and today we're going over 8 different ways you can actually treat, diagnose, or rehab actually Pes Anserine Bursitis. So here's 8 different steps that your healthcare provider should be taking to take care of your Pes Anserine Bursitis. Now when we're palpating the medial hamstring, right where my hand's at right now, you can find the tendon, and it's going to be one of the thickest tendons in that area, and it's the one that dives down just below the knee. If you have the person contract, usually you'll feel it. So I'm going to hang around this tendon right here just to make sure I am on the medial hamstring, and I'll move further up on into the actual muscle itself and adding some motion. And if you watch some of the other videos on knee conditions I had Laura in, we joked around a little bit and I got some really good feedback saying it was more entertaining to have some intermissions like that, so I threw some jokes in on this too, so enjoy. So what's the combination?
No.
What's the combination of a banker and a fish? I don't know if she's answered a joke correctly yet, but as I'm treating here, you'll see that I'm getting higher up actually into the musculature of the medial hamstring.
I don't know, a money tank?
Oh, what?
Money tank? I don't know.
A money tank?
Yeah. Is that a thing?
I don't know. It's a loan shark.
Oh my God. How did I not know that one?
So you can follow this all the way up, and I'm using my body to move her leg as well. So I do suggest that people when they do this on their own, that they say put a ball into this area right here, and you're actually going to go seated and kick the leg out. I do have another video on that as well, but this is more of like the hands-on myofascial release technique aspect. This is really, really good at decreasing scar tissue formation in the local area. Now when palpating the gracilis muscle, usually I start at the Pes Anserine again. I'm a little higher than that here, and I'm moving up to the medial aspect of the knee, and I'm going all the way up into kind of if you're going to draw a straight line from the knee to the groin, it kind of follows that distribution. And it's a very strappy-like muscle, so you can kind of feel it wiggling underneath your finger. I would work all the way up into the actual muscle with this one as well. What do you call a productive fish? And you'll see as I'm actually moving into extension with the knee, I also drop the hip a little bit as well, just because it is an adductor and also it flexes the knee. Efficient.
I like that one though.
And as we start getting away from the tendon, we start working up into the belly of the muscle. It's usually tender on people on here as well, especially when you get a little bit higher, so it's important to realize there are neurological vascular structures in here as well. There is the adductor hiatus, which is a little bit more to the front side of the thigh, but either way, people are usually really tender. So it's really, really important to be super careful. I don't suggest anybody really work on this on their own. They should go to someone who's really experienced in myofascial release because there are nerves, vessels in the area which can be really irritated. Now we were just doing a pin and stretch style technique. This is more of a stripping one. Notice that I'm not moving the knee anymore and I'm holding her leg into a position where she keeps the gracilis actually more relaxed so I can get into it a little bit better. You can do this from sideline position as well, but as long as she's holding her leg up into the air actively, it's really hard to get into the muscles. So usually I won't do on pants like this. I'll do on the skin, and I'll put some lotion, which is a little bit more oily, to be able to get some slide amongst the tissue. But the goal is to be able to separate the gracilis from the areas around it. The movement is actually kind of like a figure 4, and it goes into the thigh muscle area and actually up into the lateral aspect of the outer aspect of the hip. So this is one way that I treat it in the office here, but it's kind of a pain in the butt for everyone to do this on their own anyways, so I don't suggest it. We'll go into more of a static technique. Now the static technique, I just usually have them flex their knee like this. You could bring the hip down as well, or bring the knee down to the table and kind of strip it in the fashion that we're going towards to the outer part of the hip from the inner part of the knee. That is the path of this sartorius muscle. So usually I use lotion as well, and I don't do on pants. I usually do right on the skin. Okay, so one way to mobilize the hip, and I'm going to show one where I'm helping her, is a lot of times that we have to clear hip impingement, which is oftentimes found with knee conditions such as Pes Anserine Bursitis. So all we're going to do is we're going to wrap this thing up as close as we can to her groin, and I like to use 2 because it also adds more tension, but also too it decreases the amount of like pull into the area and tenderness she's going to get from the actual strap going just into one spot. So here's what we're going to do. Let's see, make sure you can see. So I stepped through the band right there. What's a better way to do this? Let's spin that way. Spin, there we go, right there. Cool. All right, don't kick me. Just like that. So I'm going to draw tension this way with the band. And all I want is I want her to engage your trunk here. Okay, act like I'm going to punch you. Don't let me sink through your stomach. And she's going to drive her knee up towards her chest. Good, as hard as you can. And come on down. So the more tension I put on this, the more I'm going to distract the joint laterally. Go ahead and come up. And she's actually just adding movement into flexion, which again we talked about. Go ahead. We're going to do this about 10 times. We talked about the correlation of knee conditions with hip ones. If we can improve the hip range of motion or mobility, then we're going to improve the knee. And in this case, she's having to do all her own mobility work. I'm just providing the lateral distraction to improve the joint space. Good. Now, one way we can have her do this on her own is, let's see, if you were attaching this, imagine I'm a rig or some type of baluster or something of that nature, then she could do this all on her own. I like to have them attach it so it's a little bit above the hip up here, because the whole point is to get from here to here. And if it was down here, then it's not going to work quite as well. Okay, we're going to do some mobilization of the pelvis, or I guess the SI joint would be encompassed in there as well. So this is going to be for the Pes Anserine again, but we can use it for any of the knee conditions. So what we're going to do is bring the knees up towards the ceiling there. Good. So you're going to put your hand on one knee, that'll work, and the hand on top of the other knee. So basically we're not going to move from this position, but she's going to supply some tension with her hands and drive her knees into them. Go ahead and drive. And on the video, we're not going to be able to tell really because she's not supposed to be moving, but we can see her legs twitching a little bit there. So she's working. She's going to hold for 15 seconds and then relax and then switch. Good. Hand on top, hand on bottom. And what's really happening here is go ahead and drive. So we're actually using the muscles attaching to the pelvis to move the pelvis. So we're doing one side where in this side she is driving down. So she's using some of the muscles attaching to the backside here, and the other side she's using the other stuff like the hip flexors. But basically we're trying to mobilize it with our own muscles. Go ahead and switch. And go again. You can spend about a minute or so doing this. It's actually harder than you think. I don't hear her breathing though. Good. Should be so relaxing. This is something you can actually warm up with. And switch. And again, this is a form of isometric contraction. The muscles and tendons are doing the work to mobilize the pelvis and therefore the SI joints, which are on both sides of the pelvis. Okay, we're going to be taping. This is again with a stretchy tape. We're going to be doing it onto the Pes Anserine. And typically what I like to do beforehand is I like to muscle test to see which of the 3 muscles is the one which is the culprit irritating the Pes Anserine, if there is something there. Again, taping techniques I think should mainly be reserved for pain management and improving the structures if there's a problem here. But if we're looking at a functional issue where the hip is the main issue, then we might leave this alone and not tape it at all. But what I like to typically do is, so you slide on up the shin here, we're going to find the Pes Anserine right there, and let's just say we have an issue with, we're going to go with the GRACILIS just to make it easy on the video. So Pes Anserine right there, and you can kind of see the musculature slide down and kind of become it right around here. So I'm going to provide an anchor right there. You can pull on it about 10% there. This tape, the backing kind of comes up on its own when you pull it. And I probably made this a little long, but we'll go with it. Good, so make sure that thing's really laying on there. These ones are going to form an X over the spot right there. So I like to rip it right in the middle, lay that thing down. Let's get that thing out of the way. And these ones I like to put a little bit more stretch on it. But keep in mind, this is on the front side of the knee. So if you put too much stretch on it, when she bends the knee, it's going to tear right off because it has it doesn't have any more stretch to give. And the last one here, Laura asked for black tape this time.
I did not.
She did ask for black tape.
Black makes you look skinnier. So
Black makes you look skinnier, in case no one heard her say that.
So white makes you look tan.
I'll look for some black and white tape next time. Okay, so you rub this thing on. It's going to activate some of the adhesive. You can leave this on for about 5 days or so. She should be able to move and bend with it. If there's some areas that are restricting her, like say this one back here might be kind of binding up within the bend of her knee, we can cut this one off and start again as well. So we want to make sure that she has free motion and make sure that it feels comfortable before she leaves. But again, it can last about 5 days if you take care of it and you don't end up kind of picking at it, or when you shower, don't try to rub it dry, just let it air dry. So now before we start onto the sweeps and the extension part of the Turkish getup, I'm going to start with a couple form issues that you're going to see in here. I circled one, so I just want to make sure that everybody's aware that this is not a perfect getup. So she's not stacking a weight over here. She didn't have her shoulder over her shoulder, but for the sake of getting what we needed to get done in regards to the knee, I let some of these things slide since she didn't have any underlying pathology in those areas. So just note that she should have her shoulder stacked above the other one on this one. Next, when we look at the setup, she should have a little bit more spread within her legs. So I would take her left leg right here and move it a little bit more towards the bottom of the screen, mainly because it's going to help her drive with that right heel. Lastly, when she was creating the stance point, notice how her thigh right here, her bottom thigh, I circled it, it's not making a very stable post. So you should be a little bit more vertical with it. Also, too, she is directly underneath her body, but also, too, a little bit more forward. So I would have her bring her knee much further back if I was going to correct form in this going on in the future. And again, notice that I circled her shoulders again, so we do see there is still that stacking issue. She doesn't have any weight in her hand right now, which is the major issue. A lot of times when you add weight, it'll improve form dramatically. And lastly, going into this two-step process for the low sweep that I gave her, this is mainly because I'm trying to rehab an area. I just want everyone to understand that. This is not technically a stopping point for the Turkish getup that I would give if I was getting a full getup. This is just for them to create the path, create the hip extension that we're looking for, and to build strength and rotation or mobilization within the hips. So again, this is a process. This is the second step that I made up myself because it works well in our clinic. I do plan on having a video on the full Turkish getup coming up soon, but there are some great references I'll put below the video as well. All right, so we're going to do part of a Turkish getup right here, and the reason we're not doing a complete one is mainly because we want to work on hip mobility and extension in regards to Pes Anserine. So we are going to keep this foot glued to the ground right there. Notice she has about 45 degrees roughly. Give me a little bit more. And there you go. Nice firm hand contact. Okay, and notice that this heel is driven into the ground. She should always strive to keep this part of the heel on the ground as long as this foot's in contact. Okay, so come on up. Drive your hips to the ceiling. Good. So she's looking her hand into the air, which is awesome. This hip over here is completely extended, which is what we want, and that foot is glued to the ground. And good. So let's do a little bit slower here, just so I'm going to prep again. So heel glued to the ground. Give me a little bit more knee bend. Or sorry, the other way. There you go. Hand never leaves the ground. Heel is always in contact. Bring the hand to the sky and drive the hips up. So this is the Turkish getup extension portion. Come on down. Give me another there. Hey Laura, what did one hat say to the other hat?
What did you say?
You go on ahead. And give me another. I know it's not as good as the fish ones.
Your jokes are just all terrible.
Yeah, I know they're really bad. Okay, good. So now on, we're going to go on to the next portion, which is going to include that kick again. So I want you to go ahead and keep everything else the same. Go ahead and drive the hips into the air. Now we're going to go bottom of the foot to the other foot. Good. Keeping the shin on the ground. Awesome. Pausing there. And then she's going to bring the knee behind her. Go ahead and slide it through. Good. So she's going into the low sweep portion. Come on back. Hit that step, foot to foot. And kick the heel out. Now she dropped her hip right there. Good. So drive the hip up. Up, up, up. You got more in you. There you go. A lot of people are lazy during that portion. And come on down. Give me one more here. Hip drive. Foot to foot. Pause. Shin on the ground. Shin on the ground. Kick on through. So the low sweep right there. Awesome. Come on back. Foot to foot. Getting lazy with the hips. I see it. Kick on through. Drive with the heel. Right hip up. Pause. And slow on the way down. So that is the low sweep portion. So now, let's take that foot, right foot, and slide the bottom of your foot to your other foot. Good. Lay that shin down for me. Good. And she's going to take a small break here. Now go ahead and pull that through. So she's going to bring the knee below the body, and the leg's going to go back. Uh-oh. Come on back this way. There you go. Bring the knee. We're going to go right. Put it right here. There we go. I'm going to adjust her a little bit here. You're always interactive, aren't you, Laura?
Oh, yeah.
There we go. Good. So notice the foot's still glued down to the ground. She has her knee below her, and she's still looking her hand into the air. So go ahead and kick out of that, but I want you to bring the foot to the foot again. Good. And now kick out. Drive with the heel. Let's see the hip up. And now down slowly. Okay, Pes Anserine Bursitis is one that is commonly misdiagnosed, and it's oftentimes a medial meniscus tear. Now, it's important to realize how to palpate this area, and if you've already seen the medial meniscus video, you'll probably realize it's roughly the same palpation type. So I like to take the hand, web it onto the shin right there, and slide it all the way up, and your thumb will eventually rub into the Pes Anserine right there. Okay, it's going to feel like the bone is just jutting out that way slightly, and then you're kind of hitting it. Beyond that is the
Sorry.
She's about crying. She must have an issue here. So I'm not palpating that hard even really. So inside here is the joint line, which can be tender as well when it's a meniscal injury. But for the most part right here, the Pes Anserine is pretty solid. So we have, the Pes Anserine is anatomically, it's a connection of three muscles. We have the sartorius, the gracilis, and the medial hamstring. So technically, if there's an issue here, then we should be checking these muscles in regards to quality of how they are, how they actually are themselves, but also where they attach. All three of these muscles actually attach into above on the pelvis. They go past the hip. So to think that there's not a hip condition related to this or a core one is a lot of times really, it's far-fetched. So we need to evaluate the hip as well as the core oftentimes when we have Pes Anserine. Okay, now on to the rehab section, rehab theory. I've given all the quick tips I'm going to give on Pes Anserine, so again, just like all the other videos, it's going to sound very brash and very direct at this point, but if you don't care about what your knee condition actually is, how it's resolved, how it starts, how to stop it from coming back, then you're going to want to tune out right now, because this rest of this part is not going to interest you and it's going to bore the heck out of you. But if you do care, then this is the spot where it's actually going to get the most bang for your buck on this video. So keep in mind that Pes Anserine bursitis or tendonitis is really, really commonly misdiagnosed, okay? That is an important concept when we're talking about rehab, because we have to rehab based upon the injury that you have or that you don't have. So one that is commonly misdiagnosed as, or actually it's misdiagnosed as Pes Anserine bursitis, a lot of times it's actually a medial meniscus injury, or there's some type of internal knee or an unstable knee that we're basically working with. And if you saw my video on cyst of the knee, I took this balloon, okay? The balloon basically, if you crush the balloon that's blown up, it'll escape from the top and the bottom, or if I spread my fingers enough, it'll escape from between my fingers, okay? Basically, this describes the capsule of the knee. And with knee conditions, which you're going to see in a whiteboard demonstration right here, with Pes Anserine Bursitis, we have the gutter sign which comes out. So stuff starts to kind of ooze out of the inside of the knee, and it almost drops into the area where the Pes Anserine is, or so close to it that it seems like it's tenderness of the Pes Anserine. And this is the danger that we run. Let's go on to the whiteboard. Okay, we're into the good stuff now about the Pes Anserine bursitis or tendonitis. And just to give you some reference points, I drew this stuff out. So this is going to be what we call medial, which is like the inner, I guess I'll draw part of the body right here. Let's just say this is the body. Here's the outer part of you with the lateral aspect, and here is the bone, which is the femur. Here's the tibia. Here's the fibula, which in this whole thing encompassing is the knee. So the reason why I want to draw this out again is because I want to show you the general proximity and the high possibility of misdiagnosis of these things. So now, I explained this is the femur, this is the bone, this is the joint space right here. And what I drew right here is actually, here's the medial meniscus, here's the lateral meniscus, here's the ACL and PCL, and inside this area is basically there's a balloon, okay? This whole thing is considered the joint capsule, and when your knee actually inflates from the inside, this joint capsule it finds areas to go out of, okay? And some of the places are actually Baker's, in the backside is Baker's cyst, some of it goes on the side where it kind of spills over. We call it a gutter sign, where basically it kind of comes out of this area and it starts dropping down this way. Okay, I'll fill that in right there. Let's just say it's that black right there. I'll take these away. So basically what happens is when there's a gutter like this and it starts to kind of ooze out and down and comes down the capsule, the Pes Anserine is like right here, okay? And now we do have 3 muscles attaching to it, okay? And there's the bursa right there as well, but look how close this gutter happens, okay? And I guess ignore the muscles at this point now. So there's the gutter right there, and actually there's the MCL over it too. I guess we're gonna have lots of different lines of different colors. So there's the medial meniscus, there's the capsule, which fills with fluid and goes down, and there's the medial collateral ligament right here, the MCL. And then we have the Pes, bursa, and tendon right here. What happens is when you start feeling in this area, it's like, hey, is this painful? And they're like, oh yeah, it's really painful right there. And they're like, boom, Pes Anserine bursitis. But realistically, I can't tell you how many times we go like this. So this is a ultrasound probe, okay? It shoots sound waves in there, and it bounces them back again, kind of like sonar for like a dolphin. And you can see that this stuff has oozed so close to the insertion of the Pes Anserine that people think that it's Pes Anserine bursitis, but I would say easily over half the time it's not. What happens is, again, is this thing fills up with fluid. Now it can be coming from just a macerated meniscus, an irritated meniscus right here, which could be, it could be torn, could be frayed, it could just be pinched. I mean, there could be a lot of things going on. Or it could be coming from the inside part of the balloon. And the balloon just, again, escapes anywhere it wants to. So it could be coming from Chondromalacia Patella, so the kneecap is right here, but it's floating on top. So it's just rubbing in there, and then it starts to ooze its contents all over the side. Then you think it's Pes Anserine bursitis. So here's the thing with it, is going through the exam that I showed you earlier, we're basically ruling in this versus ruling out this stuff because it's so close in proximity. And it's not to say the rehab will be completely different, but it'll stop you from addressing the muscles which become the Pes Anserine, okay? I totally believe in that if you only have 10 minutes in the day, I'd rather you do it productively for what you're supposed to do it on versus addressing the muscles which feed into the Pes Anserine, which then you might be watching this YouTube video now thinking, well, I don't know why I'm not getting any better because it's probably because you're not addressing the right thing, okay? If we work on it as a meniscus injury, you need to look at the past video I did on medial meniscus tears in runners. You'll get a better idea of how we typically rehab that. And if you're looking for a comprehensive video on mechanics of how knee injuries happen with running it's going to be the runner's knee video. Okay? I want you to go to that, and I want you to fast forward all the way through, go to the very end where you start seeing a whiteboard like this, or I stop giving quick tips. Okay? Then we go into basically the mechanics of how knee injuries happen in runners because of neuromuscular degrade or because of quote-unquote form degrade as they get tired. So what you're going to want to see if you want to confirm this or not, here's the two things that will confirm it for you. If you really feel that it's Pes Anserine, an MRI will find it. An MSK ultrasound will find it. And here's the pros and cons of both. An MRI, if you're not scared of going into a tube and sitting there still for 30 to 45 minutes, completely fine. And if you get clearance from your doc to do it or your insurance, by all means, I have no problem with this. An MSK ultrasound is probably, I'd say roughly about a fourth of the cost, and it's just as accurate in seeing this because it's so close to the skin surface. Like I said, we're just bouncing sound off of it. You don't have to get derobed, you don't have to change at all, you don't have to go into a tube, and realistically, you could see it in 5 minutes if you knew what you're looking for. An MRI is still going to run you about 30 to 45 minutes of your time after you get in and out of the machine. Okay, so MSK ultrasound, I'll put a link below where you can find something like that, and there's a whole article I wrote upon it too. Now, if you like this so far, please give me a thumbs up and subscribe to this channel. The only way you're going to get the videos in the future directly and actually right when they come out, so they're all up to date, is going to be to subscribe. So go into the corner, it's going to be, I think, in the lower left corner, I always forget, but it's a really, really tiny logo. Go in there and subscribe. Okay, it's the only way you're going to get the stuff. And if you want some good free content that I actually email out to any of my email subscribers, you're going to have to go to my website. That's p2sportscare.com. Go on there, and I'm going to put a link below to where you can get all the good current stuff that I put out on knee conditions with running. So I have a specific email list that I only do with runners with knee pain. So if you want specific content to that, go through that link and you'll be asked to put in your email. I won't spam you. If you have more questions on knee conditions that you want me to go through, like you saw that someone put a question about a knee cyst, I did a whole video upon that. So if you have questions that you want me to answer, I can do it through video format. Just let me know. Let me know specifically what you want to hear, and I'll do my best to answer it. If I can't answer it on video because it takes a little bit of editing work for me to do, I usually do it on podcasts. So if you haven't heard my podcast yet, go to iTunes, look up Performance Play Sports Care Podcast, and it's right there. So subscribe, review, share. That's all I'm asking for, and I'll give you the best free content I possibly can. Talk to you guys soon.